in life. And there's a rich literature on this, but most of these studies have looked at the relationship between birth month and health later in life, not really early in life. And then also, majority of these studies have focused on developed countries and not developing countries. So here I'm really looking at the relationship between birth month and child health. In an ideal setting, I would want to look at it through health throughout the life course. But given this data at this time, I could just really look at health up to age 5. So what are the mechanisms behind this birth month effect in health? So the first one might really be the role of maternal selection. So that might mean that children born in different months, they're actually already different at conception. So it's actually nothing to do with the prenatal or postnatal condition. It might be a selection. And I just wanted to bring back that figure from Nigeria that shows you that there are certain months that are associated with births from lower or different socioeconomic groups. And this isn't just the case for Nigeria. Research by folks at Duke, Buckles and Hungerman have shown that in the US, month of birth, 50% of the relationship between month of birth and health is really tied to this maternal selection. So in the case of the US, it's that, as someone had mentioned, the prom babies, is that a lot of the infants born, the winter babies in January, February, are more likely to be from unwed teenage mothers compared to infants born during the summer or fall. So there's definitely that selection that may just be nothing to do with in utero conditions, but really already at conception. Another mechanism behind it is differences in prenatal condition. As I had mentioned, there's some places where might be a clear defined hunger period. So infants conceived at different time are going to experience that effect at different gestational ages. So that may definitely play a role. So one of the most, in terms of infectious disease, one of the most studied one is congenital rubella syndrome. So rubella in many places is seasonal, but it's really exposure in the first trimester that has an effect. So if an infant if her mother is at the second month or second trimester of gestation and she has rubella, nothing will happen to her child. But if she's at the first trimester, that's when you actually get all the different syndromes. And what's so interesting with rubella, it's even different depending on the weeks, whether or not you get blindness or some of the different effects. So it really highlights that importance of the interaction between the gestational age and the exposures. And going back to the Zika, so that's something that people are trying to also figure out, whether or not it's exposure at certain periods, if there is a link of gestation that may...
they don't know anything about that yet.
No, they just think there might be a correlation, but we don't know, and we don't know much. But I do think some people are starting to... I've seen in the literature, some people hypothesize that it's probably exposure in the first few months when there's a lot of the brain development. But I feel like it's still very early. Okay. But then likewise, there's also differences in conditions during infancy. So given that a child's born, one example I can give is, let's say a child's born at the peak of the flu season. So a new infant actually doesn't have, well, maybe I'll give the measles epidemic, because measles you actually have some maternal immunity. So an infant born during the peak of a measles epidemic may actually be protected from measles, while a baby born 6 months before, due to waning maternal immunity, may actually be more at risk of that.
Due to what?
Because the infant no longer has the maternal immunity,
okay.
and stuff like that. So it's kind of, once again, that interaction between the exposure and the age at which you're exposed. Okay. And then actually the fourth one that people have not paid as much attention to.
Before you go on, could you say something about the breastfeeding effect?
Yes, so the breastfeeding, So there's some studies that you could think that there's an interaction between your month of birth and duration of breastfeeding. So once again, if there's an agricultural setting where there's your harvest period, maybe kids born at certain times may have shorter or longer breastfeeding. And if we think breastfeeding is tied to other positive outcomes, and also just with weaning. So kind of some of those interactions. So the fourth mechanism is really due to confounding, due to missing information on gestational age. So a lot of the studies, including mine, I only have information on month of birth. I don't have information on gestational length. Right. So my new research, I actually do have that and can control for that in the US, but in this setting, this is really the best I could do, but it's important to take note of this, and I'll explain a little bit more, because it can make us, I guess it helps in actually evaluating some of my results. And actually, in the people who I think did the best to bring this potential mechanism to light is recent paper by Hannah Schwant and Janet Curry at Princeton. And this confounding is really due to the interaction between conception rate, seasonality, and the distribution of gestational ages. So what that means is that, let's say we had just 2 months of conception. Okay? So that means the period that, and one was the peak month of conception, one wasn't. So then the period that falls 9 months after the peak in conception may actually be associated with better infant health outcomes, because on average, there will be fewer preterm births during that month, because all the preterm births, the majority of them, would have been born before. So it's one where it actually has nothing to do.
Right.
It's kind of some of that. And if you don't have that gestational, so like for example in the US, you could think that if September is the peak birth month, and September, I'll have to look, September is also the best month to be born in, that may actually be because all the preterm babies conceived 9 months were born in August. So they're not showing up in September. So very few studies have actually paid attention to that at all. But as I said, given to the data, sometimes you can't. So in my study, I do try to pay attention when the birth month that's associated with the best outcome, if it's also associated with the peak birth month, then that tells me that maybe it might be overestimated. Like this birth month effect could be biased, so it could be due a little bit to the confounding. But as I said, there wasn't much I could do with this data, but it's something that people haven't really thought about, but it's just a mechanical factor that's present with all of the studies that just use birth month and don't control for gestational age. Okay. So the research aims and questions for this project. So, and actually I'll go backtrack. So in the paper, I look at the relationship between both birth month and survival. And I also look at birth month and child growth as measured by stunting. But here, I only present the results on survival. So here it's really what is the relationship between birth month and child survival in Sub-Saharan Africa. And I really wanted to kind of unpack the birth month effect. So is it factors happening at conception, so maternal selection? Is it prenatal factors, or is it postnatal? And with the conception, it would be kind of trying to see if it's maternal selection. The prenatal, one of the ways I try to get at this is by looking at the sex ratio at birth, because there's this hypothesis that you see increased male fetal deaths due to an exposure. So it's actually looking at to try to see if there's maybe selective survival in utero by looking at the sex ratio at birth.
So you're looking for more females at birth means that there was like worse in utero.
Exactly.
Male fetuses are more susceptible to.
Yes.
Okay.
So it's looking at that, but that would only show me, so if I don't find a pattern, that just shows me that maybe the exposure wasn't strong enough to induce fetal loss, but there could still be a factor. But to the extent that I could, I was trying to test that. And then postnatal. So what I actually tried to do is that, and I'll describe this a little bit, is just try to see if the birth month effect, if it changes with age. Because
Whose age? Mother's age?
no, the child's age.
Oh.
So, like for example,
I
if
see.
there's some, because it could be that like babies born in September have better survive, but then later on the relationship could change. If there's and there's been some studies that have found something like that. Okay. So in terms of my data and methods, so this was using, so I have data from 30 sub-Saharan African countries, and I use the demographic and health surveys, which have retrospective birth history. So I have information on every birth a mother has had, but because of recall bias, I do limit it to births within 10 years of the survey date. But then if a child has died, I have information on age at death. And then my key exposure is month of birth. And I don't talk too much here about data quality, but all this analysis is only I only know when we do know the month of birth, because the DHS actually in some cases imputes birth month and stuff like that. And then I have controls, so I really try to control for the well-known proximate determinants of mortality: sex, birth order, birth interval, some maternal characteristics, mother's education, mother's age at birth, rural urban residence. And then finally, what's really nice is that I have information on if children have the same mother. So then I have mother ID, which allows me in some models to actually have mother fixed effects. So the way I did it really kind of started here, where I first used a piecewise exponential hazard model. And I did this because of the discrete data, nature of the data and censoring, and really because I wanted to be able to do interactions between birth month and age-specific hazards. And then using this information, I was actually able to calculate the cumulative survival probabilities, and then turn them into under 5 mortality rates. And then I use OLS regression to look at the proportion of males at birth for this analysis.
Before you go on, can I ask a couple of questions?
Yeah.
Now, did you check on the pattern of missing month data and whether that was selective?
Yes, yeah. So I did look. So for some countries they were better than others. So I think on average it was less than 5%. There was a few countries where it's extreme, but most countries did not have that much missing birth information. But then when information on birth month was missing, it was more likely to be from rural and poor and less educated mothers. So that would tell me that maybe some of the, so those might be some of the folks with the worst outcomes. So maybe my estimates may be biased, like maybe lower estimate. But I did try to see if there, and as we would expect, more rural, I think older, poorer moms, are less educated.
Okay. The other issue is recall on when the baby died. That could also be an issue, especially if it happened a long time ago. I mean,
so I did narrow the window, and I think, once again, the DHS data has some flags. So I think I also did make sure that's when it was noon. But I don't...
You said 10 years?
10 years?
No, 10 years, so I only included births that... So people may know the exact age at birth, but if it's before 10 years prior to a survey date, I didn't include them, but then there could be some instances where they know their month of birth, but there was very few number of observations where I did not include them, where there was missing information on age at death.
Yeah, it's not just missing.
It's just missing, it's some selection, and in the paper I do, because the reviewers, which were economists, I found I did spend a lot of time actually doing checks, and also, and I don't show it here, looking to see, regressing to see, so I guess they had me to see some data quality checks, to see if some of the countries with the largest data quality issues were those the countries with the highest birth month effects or not. Like, was there a relationship between data quality and my demand? And there wasn't. And there are a few other tests, like robustness checks I did. Because the issue is that the DHS is the best we have, but then we should also be cognizant of some of the potential issues.
Can we silence cell phones? Like,
that.
seriously, guys? It's pretty rude.
Okay. So then, to actually do the whole mother's fixed effects, what I ended up using was a Cox proportional hazard model. So that allowed me to control for individual and maternal covariates. And I also found that it was acceptable to use the Cox proportional hazard model, because when I did the piece, and I'll show that you guys that, when I did the piecewise exponential hazard model, I actually found that there wasn't much of an interaction between birth month and the age-specific intervals. So it's kind of, the effect was constant throughout. Okay. So the results, and I'll show that a little bit more in details in the next few slides, is that birth month was actually highly predictive of child survival in the majority of countries in Sub-Saharan Africa. So that means people born, let's say in the same year, but in different months, you don't have the same probability of surviving to age 1 or surviving to age 5. And I think with a lot of the MDG goals to reduce under 5 mortality, people just really did not, like, we're like, oh, there's some months where there's increased number of deaths, but people did not look at this seasonal aspect, that there are certain birth cohorts, if you're looking at birth month, that may actually be at increased risk.
Is it a substantial difference?
Yes, so I'll show in a little bit. The other factor that finding that I found is that birth month effect is usually constant across the different age intervals. So if if in the neonatal period there's a birth month that's worse, at every age it's typically that same birth month. So I wasn't seeing like crossover effects or so on. And then third is that there's a lot of variation in this birth month effect of health in Sub-Saharan Africa. So it's not always like, oh, June throughout for the entire continent is the best month. It really did vary from region to region, but you did see sometimes some neighboring places would have some similar patterns. So let me show you. So this is a figure showing the probability of dying by age 5. So this is the under 5 mortality rate. And here, this is the extremes, but I'll show all the months later on. So this is comparing the worst versus the best. So you see that here these are large, and these are ordered in magnitude. And you see the large differences between the under 5 mortality rates for the 2 extreme months. So this is quite,
So this is just raw, right? It's not adjusting for any sort
it's not adjusting, and stuff like that. Okay. So it's just
comparing.
So I was just like, wait a minute, like it's Okay. So these are the results of the piecewise exponential model. So once again, showing the worst and the best. As I said, I'll show all the different data, and I also do later on joint significance tests, so that it's not always just the 2 extremes. But you see that so I guess this is what I was surprised. So I remember some folks when I was first doing this, they didn't think I was going to see any difference in the neonatal period, because that's the time where there's the highest mortality. So they're like, oh, it's bad for everyone. You're not going to see birth month differences. But I'm seeing birth month differences starting from the beginning, and it just keeps on going. Once again, like Liberia, Malawi, Namibia. And so out of my 30 countries, the majority of the countries, I'm seeing that the interaction between month of birth and the age-specific intervals, so these intervals, were not significant, but there are 6 countries where they were. And these are the 6 countries: Burkina Faso, Congo, Democratic Republic of Congo, Ivory Coast, Nigeria, and Tanzania. So you see in these countries where there may not have been at the beginning, but then definitely towards the end, or some where it increased more rapidly than you would expect.
Do you have any explanation about that?
Yeah, no, so that's actually why for my next projects, I don't look at so many countries, or I do one specific country where I can really dig in. So the benefit of the DHS is that I could look at a lot of countries at once, but the downside, and this is when I feel like I need a lot more information about the countries or the specific patterns, like to really understand. So I can show you what, I can't explain why. So for these, I would just need a lot more in-ground or in-depth information to just, yeah. So, but here I'm highlighting that there are these effects, and I'm hoping folks will, say, let me try to understand or dig into like what might be some of these causes. Like the only what I can test for is if it's at maternal selection, or if it's, yeah.
Okay, I mean, could it be because of seasonality in death?
Exactly.
That's pushing, and let's say babies are vulnerable at a certain age, and if they happen to hit that age at the time where death is more prevalent, they die.
Yeah, so it could be. So for example, in the US, with the flu, so we know winter, sometimes there's flu deaths. So for that one, for a lot of the kids, you would see, so in the US there was a crossover data where for babies born in the influenza, it's really bad because like you don't have maternal immunity, they die. But then you would see, but usually infant mortality, the hazards decrease, but for a lot of them, when they reach that bad period, that winter, you would see a slight jump. So it could be that, so there could be that effect, but I feel with some of these crossovers, maybe if some of the countries, especially Niger, where there's just really high mortality, in some places, maybe there's that selection, that selective survival where most of the least robust have died, so the birth month associated with the worst outcome a few years later becomes the birth month associated with the best outcome.
Yeah, so because so far it looks like for most, I'm generalizing here across like all of these tables, like it looks like the difference in mortality rates between the worst and the best month are pretty constant.
Yeah.
Through the time period you're able to, the ages you're able to look at. But like, so eventually you would expect them to narrow, right?
Yeah.
And due to the selection sort of effect, do you think that you're just not looking at far enough out?
Yeah, so I don't have the data, so it could narrow. And actually, when I look at, so that's where sometimes some of the stunts, like some of the other stuff, I could see more.
Because like eventually you'd even predict a reversal.
Yeah,
right?
So
because all the weak babies have
yeah,
died.
so there are 2 countries with really high mortality. So I think it was like Niger. Let me go back to the. Yeah, so it was Mali and Niger. It was in Mali, or maybe Mali and Chad, where when I was actually comparing the stunting results with the mortality, you almost saw different patterns. So the months associated with the worst mortality was the birth month associated with the lowest stunting.
Yeah,
exactly. Yeah. So in the paper where I compared kind of some of the morbidity or the health versus the, there for the countries with the extreme mortality, you already start to see some of that selective survival. But then this also gives me caution because, as I said, a lot of the existing studies look at birth month and later life health. Because a lot of the studies were, because they were looking at the health retirements or other stuff, so it's like given that you survive to age 50. So I'm like, wait a minute, there may have been all this early selection that might have happened before. So I do feel like the gold standard would be to actually just be able to look and follow people over time, but you really need these cohort studies and
Audrey, what do you? I don't expect this accounts for a lot of the difference because it's probably a small n. But I'm just thinking about the interaction between birth month peaks and what we know about things like shortages of infant adapted vaccines and immunizations in parts of sub-Saharan Africa. So what's the possibility that we've just got bad predictive data so that we have insufficient medication when we have a peak in newborns because we're using recent months as opposed to...
Yeah, so like those are things that, so you're saying that maybe there are certain months that are associated with worse outcomes because, let's say, so I guess you could think that maybe the peak birth month may be associated with poor infant health. If there's just not enough doctors for all the neonatal. Yeah, so those factors could maybe explain, like, if there's not enough, like, room at the hospital during that time because the doctors have a gazillion patients at the same time or vaccines. So those, I definitely have to think about that somewhere. And as I'll show in the future work, so for some of this, to continue this, I'm hoping to use DSS data. I was invited to do some stuff with DSS data for Senegal, but then there was the Ebola outbreak and other stuff, so I was just like, maybe not. But now I am starting to have access to some good data from Haiti for a center, so that may be something that maybe in that context I can look. And especially since I didn't even volunteer when I told them I did birth seasonality, it was actually the doctors, they're like, oh, we know in Haiti it's November, big peak. Like we always, like that center actually was already preparing to get ready because they know they have an increase in obstetrical patients and stuff like that. So
are you looking at what Mike Osterholm is doing?
So I do need to speak to him because on some of the other, I realized he's been on the people I need to speak to, just because we have a lot of shared interests and things like that. Okay. So here I'm going to show you the data. Instead of just showing you the best month and the worst month, I'm going to show you all of the data. So here, these are the months of birth arranged from January to December, and these are the countries in my sample, and they're arranged north to south, east to west. Because I was trying to see if I was going to see some geographical patterns, but this isn't necessarily the best way. This is the results from the hazard ratio, where for every country, and I ran separate regressions for every single country, not pulled it out because I was expecting some of these differences. But for every country, the month with the best health outcomes, it has a hazard rate. It's my reference, so it's 1. And the worst, you'll see the darker. And then what you'll also see on this axis will be p-values that show the joint probability. It's a joint significant test. Just because sometimes when I'm looking at extremes, I'm going to find significant difference. So when I was just comparing between the extreme and my reference, I always found significance. But here I'll show you that for, once again, those southern African countries where there wasn't high birth seasonality, it's also not significant, jointly significant for the birth month effect on health. So let me show you. And I guess, I never know how the colors are going to show up. But you can see Sierra Leone. So Sierra Leone was the country, remember, with really high birth seasonality, where the best birth months were around the beginning of the year and the worst. So this kind of seems to follow the pattern. But Mali, there wasn't that much variation across the, I guess the colors are not showing up as much. But these are some of the Sahelian countries where I do see some geographical where maybe it's better to be born at the beginning of the year. But these sub-Saharan African countries, the southern African countries, you see a lot of pattern, but that's because these countries already have lower mortality. But also these are the countries where when I put the joint significant test, these are not actually jointly significant from each other. And that's also because I think the data, there's the confidence intervals right. So here,
so you're testing all of those months.
Those months,
Different. Only different from one.
Yes, from one, just as a more conservative test than just looking at the reference,
Sure.
and stuff like that. But for most of the countries, so once again, Togo was that same country where my birth seasonality pattern wasn't significant and the birth month effect pattern here. But I think that one was a data quality issue for Togo. So in many southern African countries, the birth month effect was not jointly significant. I don't show the results here, but when I looked at the male to female sex ratio at birth, it actually did not vary by birth month. So that doesn't tell me that there's no prenatal, it's just that it wasn't big enough to induce the fetal loss. I'm gonna show you some of this. So maternal selection. So when I did the proxy proportional hazard model with the fixed effects, I did see that actually in many of my countries, the birth month effect was attenuated So in the third of the countries in my sample. So in many of the countries, it was really the fact that women of different characteristics, which we know are so correlated with health outcomes, were actually giving birth at different times of the year. So it's just like in the US, where I've said they think 50% of the effect is due to that. But then there's still a large number of countries where the birth month effects actually remain highly significant after controlling for maternal selection. So in those countries, maybe there are some of these seasonal factors still playing a role. And I just actually want to show you some more figures. So this is what my majority of my countries look like. So model 1, so this is with no control, this is with individual level controls, all covariates, and then the fixed effects. So you saw that, so here this was relative to January, that this was the worst, but it's attenuated, kind of the differences got attenuated with the fixed effects. But there's some countries like Ghana where maternal selection may actually have been masking some of the seasonal. So it's not always the case that maybe sometimes the best educated women were giving birth at the worst months. So that may be, yeah. So here it's actually like when I add the mother fixed effects, it actually had an increase. But that was just a few countries where I saw it was actually the opposite. But then there were still a few countries that everything I did, the pattern was always pretty much steady. So for Kenya, I'm like, okay, it's probably not social factors, maybe it's some seasonal factors. And actually, if people know Kenya, what's interesting is that these are almost, I need to double check if it's this or this, but there's a bimodal rainy season, like maybe, so that's when like knowing more about the countries might help you understand what's going on at which birth month. But as I said, this really takes a lot more in-depth research, and then also it's not, and then maybe non-linear interactions, so like you really do need to know a little bit more about the country and the exposures to really know what's going on.
No, that should be November.
So is it November?
Season, the short rains in November and the longer rains in like March, April.
I think around, yeah. But then as I said, it's understanding the dynamics. So is it right at the beginning of rainfall, or is it after rainfall a little bit? So it's, yeah.
And there's much more malaria.
Yeah, what are the effects, right? Like,
Yeah.
are people inside having more sex, or are like the women less susceptible to things?
Yeah, so that's
Because
just
they're
that.
also
So
malaria,
I
like,
do,
what's
yeah.
going on?
So I guess one thing I'll do, so this is why when my other work that looks at the US, there it's like I test one hypothesis, where I have one data. I'm like, okay, I'm just testing the effect of seasonality of seasonal influenza on these outcomes. So, but it's really figuring out the data, and I guess I'll show you in one step. So, but overall, for Sub-Saharan Africa, I found that birth month has a large and statistically significant impact on child survival. But the effect might be actually overestimated in places with high birth seasonality. So it's not just that, it's when the peak birth month corresponds with that best birth month. So yes?
No, I was wondering why you didn't superimpose the prevalence of birth patterns with the survival pattern.
Oh, I should, yeah. So I have done it. So in many places, it's just, yeah, so in some places, like Nigeria, I think it was like the reverse. Like, so it could be where most people are born in the best month to be born. So there's been some other folks where, and I guess that's where some people I think have gotten ahead of themselves. So this is someone, actually a Harvard PhD dissertation, where they assume they did, that paper was never published, but they said that, oh, everyone knows the best birth month to be born. So they did a model on trying to say that there was a trade-off between that's arthritis, but they assumed that it was known and that they thought people were purposely want to give birth during the best birth month. So then they only didn't do it if there was a trade-off between kind of agricultural labor or something like that. But for me, I was just like, I don't necessarily know, or I don't think people necessarily know. And once again, and maybe
are
someone...
are that able to control their fertility?
Yeah, people are, yeah, exactly, or people that able to control.
Yeah.
Or then, if you have some of these effects, it could be because of that, that confounding. Or maybe some other people have said, maybe if you have a pulse, it might be protective. I don't know, some, Well, we don't know, but I should maybe do that in the future, because I think at the beginning, I do think in many places that birth month effect, it could be some of that confounding effect, but in some places it wasn't. But it's just doing it for 30 countries. But I had, like, one of the first things I had done a long time ago was to actually put the two patterns, birth amplitude versus birth month effects. So the birth month effect is significant as an effect of so that hazard ratio is actually pretty large and similar in magnitude to some of the other more well-known proximate determinants of mortality. And I guess for the policy implications is really, even if you're interested in under 5 mortality, maybe some of these impacts are already occurring. And I think there is a consensus that prenatal and infant period is really important in terms of targeting resources. But then I also think a lot of the programs should take into account seasonality. So there's been mixed results with the effect, for example, of maternal feeding programs. But then maybe if you're targeting a woman when it's not the hunger period, you may not see that much of an effect. So maybe if certain policies or certain things geared towards pregnant women were focused on the times where there is that hunger period or most at risk or something like that, we might see larger effects, or just being cognizant that certain things may be average out. So what I would like to do in terms of this African data is not look for 30 different countries, maybe not even look at a national level, but using data from an HCSS. So the one I've been invited to work with is folks in Senegal, but this is not data from Senegal, where I would really like to test maybe the potential impact of specific factors, so like malaria or other seasonal disease or nutritional status. But even with malaria, it's really hard because ideally I would like monthly malaria incidents or something like that. And usually sometimes I've seen fevers or other things that increasingly are not tied to malaria. So getting that temporally specific data is actually pretty hard. And has been one of the challenges.
I mean, it's hard enough in the U.S., I can't imagine anywhere.
Yeah, and then also nutritional status. I think some people have looked at food prices or certainly they're trying to get something, but just once again getting some of that information. But this is just a figure from Andrew Prentice at Harvard, where this is actually from a HCSS site in Gambia, where they had actually followed women over time. So they actually also did like hormones and stuff like that. So here they actually, you see that the weight can actually change. In this study, actually, this is where you can see it might also be driving birth seasonality, because they look at some hormone that's tied to probability of ovulation, and you saw that it did vary with the maternal weight and things like that. So if I'm to follow up with this paper, it's really trying to get that in-depth information. So that's on hold for now. But what I have done, and I guess overall future work, is that there's many different factors that may be at role, but given my interest in disease, it's really the role of potentially infectious disease or exposures in utero, and even postnatal, and what implications that may have for infant and I guess health throughout the life course. So my other paper, my most recent paper that I hope to be it's overdue in submitting, will be submitted soon, is actually looking at, in the US, the role of influenza. And there I'm finding an effect. But then in the future, as I said, especially with the Zika outbreak, I'm sure a lot of people are going to be looking at the role of exposure, in utero exposure to Zika, and it's not an understanding like when in gestation, is it the first trimester, second trimester, all of these different outcomes. And overall, that's it. And thank you so much for coming to the presentation. I got lots of really good questions.
Well, you may have more.
Yeah.
Well, I just have a comment. Joe Ritter just sent me a paper on how, on influenza mortality and the Super Bowl. Yes, serious seasonality. So it turns out that cities that have teams in the Super Bowl have higher influenza mortality. Yes.
Because everybody's all together transmitting.
I could think, it's a
double
transition.
dipping in the dip.
Yes.
Yeah. Well, did you see
What-
those
what's
terrible?
double dipping?
Yeah, actually,
Yeah.
I
Like, so
actually,
they take their like, you have your like bowl of like dip, and you have like your chip, and you're like
Yeah.
double dipping, and like.
yeah, so
spreading
for
it
the,
around
yeah, so
everywhere.
for influenza, this paper that I'm looking at in the US, I was only able to look at large counties. So for that one, I'm happy because I'm like, oh, I do think it's a population is an aspect of it. But I did actually debate whether or not to mention that whole Super Bowl babies commercial
Oh my
ad.
god, that was
And-
like the freakiest thing.
But the reason is, and some demographers have spoken about this, is because actually in the US, like it's September, but I think now increasingly like October also has a lot of births. So it's like it doesn't have to do with the Super Bowl. It could be due to the Super Bowl, but
they
it's
claimed in the commercial
Yeah, so
that
they-
cities that win the Super Bowl have more births.
yeah. So I think it's just dumb. So
And
some
like they had like choirs of like kids like that
I
were like
saw
labeled like Super Bowl babies. I'm telling Deborah because I'm sure she
Oh,
didn't
you
see
didn't
it.
I did not
It
see
was
it.
so disturbing.
Yeah, no, so I think people were really
So
disturbed.
disturbing.
So part of it is that it coincides
It was
with the
really
overall
disturbing.
peaks in births in the US.
Yeah.
But then there
Yeah.
have been studies, like you would really have to compare
There's multiple.
places that have the, and instead of just the general pattern. So there may be some truth, but I'll have to look at some of the research or some of the
Well,
data,
I
but
think Sarah was telling me because we watched Super Bowl together that back in we do that.
was it Boston 2004?
She is a big soccer fan, so she claims that there is such a thing as World Cup babies, and that's like a worldwide phenomenon. So I don't know.
It seems to me there are an awful lot of these blank babies. When we
Yeah.
talk about prom babies. and,
Maybe
you know,
that one I
so-
get. Football, I just don't get it.
Yeah, I don't get it either.
It doesn't make me feel amorous at all.
Yeah.
I have a question about how to think about Zika as we also are hearing about places like Brazil where there's pressure on the government to ease up on its
reproductive.
pregnancy
Yeah, right,
termination
exactly.
policies.
Right.
So when we have something like this where there's so much visibility and we know the implications and they're dire, might it be impossible to really measure what's happening because those babies may never be born?
Oh, you mean like in terms of maybe increase
Abortion.
So I guess maybe, so to the extent where people know, but like there in Brazil, there's very little abortion, so
No,
we
but
would.
there's
that's not
really-
true.
Oh, there's
That's not true.
undocumented,
There's
yeah.
lots and
Yeah.
lots
Lots
of
of
abortion,
abortion.
but it is all illegal.
Illegal.
Yeah, and so now when we have
Yes.
this, even the Pope is saying, let's at least talk about this. Might it have these all kinds of unintended, like might we have safer abortions in Brazil because of that? And might we have?
Totally. So I
think
do
it's
know
a-
that so some of the papers, and I need to find the articles, they say that it's not the first time that an infectious disease has actually been tied to like talking about reproductive right and abortion. So when there was the outbreak of the rubella or like German measles in the past, so like there have been periods, and especially with the congenital rubella syndrome, it can actually have some really dire circumstances. I feel like that was another instance in history where people have pushed for more liberal, I guess, like improve reproductive access through contraception and increase access to abortions.
When
and
was
some of
that? When did that occur? Did that occur in like the mid 20th century?
So it might have, I have to figure out when, but they said
Okay.
that was another time where there was a big outbreak, and once again a push for
1965.
Exactly.
66.
Or big-
65.
So it was pre-MMR vaccine, obviously.
yeah.
And then,
That was the
Pre-worldwide
last big
distribution.
wave.
Yeah.
Here.
That's
Yeah,
the
but
last
we're still
big
seeing
wave.
it in some
Okay.
other places. Yeah.
Well, Audrey, this was terrific, and I think you've given us all a lot to think about. We hope to have you back when you've solved the Zika problem.
It's just interesting. So it's like obviously a lot of us would like to get our hands and actually try to be able to study, but it's figuring out exactly the data. Because as I said, for Zika, a lot of the cases are asymptomatic and not. So then another thing is that like, do you have to be symptomatic to have the? Yeah. So that's
they haven't even proved a link yet.
yeah, that's another
You know,
link. So I feel like
yeah,
it's
so
tentative, but
it's
I know
really
some people are like, oh, why is it the first time that we might be seeing this link? are people noticing? So at that point though, in places where Zika has already, like, is endemic, most of the population may have had it.
Yeah.
So it's because I feel like it's only now that you have a large population of reproductive age susceptible folks.
Yeah.
Or before. So it might be something that's happening now, but if everyone gets it, in a few years you may not.
There may not be this effect anymore.
Yeah.
Well,
So are
let's
you
show our
worried about the
appreciation.
implications for the Olympics?
Yeah, no, so a lot of folks,
That's
especially
huge.
since yeah. Because
Maybe
the
that'll be-
Olympics
maybe
then,
they-
because
it'll be
then the
less like
Olympics
Olympic
then-
Village.
no, because the Olympics,
Sites
that's when you
around.
may actually be spreading it to the US.
Yeah.
Because if you have a viremic humans, because
Yeah.
then we'll actually have the mosquito around.
Or we could spread it across the world.
Yeah, well, as I said, so my fiance, I think he got tested at travel medicine. They sent his blood to CDC, but he wasn't so worried about coming to Minnesota infected because he's like, there's no mosquitoes
Yeah.
to
At
bite
this
him,
time,
and
yeah.
at this time to
Well,
bite
yeah.
and spread the disease around. Because I actually
That's,
met quite a few Minnesotans who were in Puerto Rico and Mexico, and also, so I wouldn't be surprised if there were a few of us who did get it while, warming up, in the during the winter
for sure.
break. But luckily,
And that-
there's no mosquitoes right here.
And
to
that
help us.
that particular mosquito doesn't live here.
Yeah. But I guess if you're in New England, like some of the others. Yeah.
Well, thank you, Audrey, very much. In 2 weeks' time, something completely different. Ed Getz is going to be talking to us about exclusion and citizenship in French urban housing policy. So he was there all of the first semester, and he's giving us a report on that. Thank you.
That was great. Glad I was here.
But I feel like for that one, the data, like sometimes I was like, I did everything. I was just like, no one did it because there was bad data or not great data. I did make the best of the DHS. But then that's why for my next project, I was like, I must have gestational age.
same
or
enrollment as
I must have.
but being too strict on the
Before,
data.
the
No,
last
because then you never go anywhere.
Oh,
So I was like, at
okay.
least you
So
know
you're
They
something.
only
self
work on the
emergency as you
US.
have
Yeah.
somebody lined up or something and you.
No, I'm just
Yeah.
wondering, I want to make sure that
So-
if I
Nice job, Audrey.
do,
Thank you.
if we do end up going that way, that we
Yeah,
have time
that
to
would be good,
process
but
that
yeah.
through HR and everything,
Get them off.
and get
So
them,
who are you?
paid when they.
Sorry, I feel like you're the only
when they-
person I did not know in the room.
My name's Evan. I'm just interested.
Oh, okay, no, because I was just like someone who I actually don't know. Like,
thank you.
but thanks, sir. No, but like the paper, this birth month and health, like.
So fascinating.
But the problem, it's not the problem. I need to get the word out there because before it was in a journal that I realized a lot of people didn't have access to.
Yeah, right here.
So now it's publicly available in PubMed. So I'm hoping to do I have to work with MPC and their I want to do a little push, to figure out how to get more people to at least read or pay
Thanks,
attention
Julie.
to it.
I think